Hello, welcome to the podcast. Today we are stepping away from raw hypertrophy mechanics to address the ultimate physiological anchor of male endocrinology, testosterone replacement therapy, or TRT. Over the last decade, the line between legitimate clinical medicine and underground bodybuilding protocols have become dangerously and often deliberately blurred. We are seeing a massive surge of athletes self-prescribing exogenous hormones, using TRT as a permanent bridge between massive steroid cycles or adapting it indefinitely after stepping off the competitive stage. We are going to deconstruct exactly what clinical TRT actually is, how it systematically overrides the HPTA axis, the stark reality of testicular separation, and the exact pharmacological doses that separate true endocrinology from prolonged anabolic enhancement. It's time to strip away the locker room brew science and look at the raw clinical data surrounding long-term exogenous testosterone administration. Let's lay down the foundational baseline of what TRT is originally designed to do. True clinical testosterone replacement therapy is a medical intervention strictly reserved for clinically diagnosed hypogonadism. This means a man's endocrine system is fundamentally failing to produce adequate testosterone due to either primary testicular failure or secondary pituitary dysfunction. The goal of genuine TRT is not to push patients into extreme upper limits of the physiological range for maximum anabolism. The singular objective is symptom resolution. It's designed to restore baseline metabolic function, stabilize neurosteroid pathways responsible for mood and cognition, and protect long-term cardiovascular and bone mineral health. When you introduce exogenous testosterone into a clinically deficient system, you're simply giving the body the physiological baseline it needs to operate normally, returning a falling endocrine environment back to the state of biological homeostasis. Now, this is where the medical theory completely fractures in the real world of enhanced bodybuilding. In the competitive sphere, athletes do not use TRT to resolve natural hypogonadism. They use it as an infrastructural tool, known as a cruise. When a bodybuilder comes off a massive, multi-compound blast phase, their natural testosterone production is completely paralyzed. Instead of suffering through a grueling, catabolic, and often emotionally catastrophic post-cycle therapy, they implement a cruise dose of exogenous testosterone to artificially sustain anabolism, hold onto contractile tissue, and keep the psychology stable until they initiate the next blast. And when these athletes finally reach the end of their careers and retire from a stage, they face a grim reality. Years of continuous supraphysiological androgen exposure often leave the Leydig cell permanently damaged, and the pituitary gland completely desynthesized. For many retired IFBB pros and enhanced athletes, permanent TRT is no longer a lifestyle choice. It becomes an absolute biological necessity just to function as a normal human being, permanently replacing the endogenous system that they intentionally shut down years ago. This brings us to a part that trips up almost everyone. And it's a biological reality that causes a lot of psychological distress for newer athletes. The absolute suppression of your natural testosterone production. Let me be perfectly clear. There is no such thing as simply supplementing or topping off your natural testosterone with an injection. The human body operates on a strict, highly sensitive negative feedback loop. via the hypothalamic-Pituitary-Gonadal axis. Think of it like a digital thermostat in your house. If you bring a massive industrial space heater in the room, the thermostat registers the extreme heat and completely shuts off the central furnace. When you inject exogenous testosterone, your hypothalamus immediately detects the hormonal surplus, halts the secretion of gonadotropin-releasing hormone, which then instantly stops the pituitary from releasing luteinizing hormone. Without luteinizing hormone acting as the chemical signal, the Leydig cells in your testes completely cease production. This suppression is absolute and profound. Within weeks of your first injection, your natural endogenous production completely drops to zero. You become entirely reliant on the exogenous compound, which leads directly into the massive elephant in the room that terrifies young athletes: fertility. If your natural testosterone production completely shut down, what exactly happens to your sperm? The reality here is highly sobering. Spermatogenesis, the acute manufacturing and maturation of sperm cells, is heavily dependent on follicle-stimulating hormone, or FSH, acting alongside massively high concentration of intratesticular testosterone. When exogenous testosterone shuts down the pituitary gland, FSH plummets to near undetectable levels, completely collapsing the local intratesticular environment required to sustain viable sperm. A comprehensive clinical review established that exogenous testosterone therapy includes severe oligozoospermia, which is clinically low sperm count, or complete azoospermia, which is a total absence of sperm, in over 90% of male patients within 3 to 4 months of initiation. While fertility can often be restored over time using secondary compounds like HCG or HMG after you cease TRT, prolonged exogenous exposure heavily degrades both sperm morphology and mobility. Treating TRT as a casual supplement is a massive, life-altering variable for anyone planning to build a family. Let's look at what's actually happening under the hood mathematically, because there is a massive misconception about human natural production versus the numbers you put into a syringe. A healthy, elite TA human male naturally produces anywhere from 3 to 10 milligrams of testosterone per day. That equates to roughly 20 to 70 milligrams of pure, unesterified testosterone per week. Now, when you inject something like testosterone cypionate or enanthate, you're not getting 100% pure testosterone. You have to account for the ester weight. For example, in 100 milligrams of testosterone cypionate, the attached ester accounts for about 30% of the molecular weight, leaving your body to cleave off roughly 70 milligrams of actual bioactive testosterone. Therefore, a strict clinical exogenous dose of 70 to 100 milligrams of testosterone cypionate per week perfectly mirrors the absolute high end of elite natural human production. Anything pushing significantly beyond that ceiling is fundamentally shifting you out of replacement therapy and crossing the threshold into supraphysiological enhancement. So, how is this highly regulated process actually administered in a modern clinical setting? The absolute gold standard for TRT revolves around injectable esters, primarily testosterone cypionate and enanthate. These are medium to long-acting delivery systems with a half-life of roughly 5 to 8 days, providing a relatively stable systemic release. While legacy clinics used to prescribe massive biweekly injections, modern evidence-based endocrinology has heavily shifted toward microdosing, administering smaller precision doses every 3 days or even every other day, which drastically flatten the peak to trough blood fluctuations. And it directly minimizes aromatization into estrogen and prevents dangerous spikes in hematocrit and red blood cell count. In European clinical models, you will frequently see the use of testosterone undecanoate under brand name like Nebido, which is a massive slow-release depot injection administered every 10 to 14 weeks. There are also transdermal gels and creams utilized for needle-aware patients, providing a daily pulse of testosterone that mimics the natural circadian rhythm, though transdermal absorption rates can vary widely from patient to patient depending on skin permeability and local receptor density. Now, let's contrast those highly calculated clinical protocols with what's actually happening in the trenches of the bodybuilding community. When an enhanced bodybuilder drops down to a cruise phase, they're almost never dropping back to a true physiological baseline of 80 to 100 milligrams. A standard modernized bodybuilding cruise typically ranges anywhere from 150 to 250 milligrams a week. Let me be perfectly clear. 250 milligrams a week is not a TRT. That's a mild perpetual anabolic cycle. This dosage is intentionally designed to keep serum testosterone levels hovering well over 1,000 to 1,500 nanograms per deciliter, maintaining a perpetual state of heightened nitrogen retention. While this definitively protects the exorbitant amount of muscle tissue built during the blast phase, it also ensures the athlete remains completely shut down endocrinologically, places chronic low-grade stress on the cardiovascular and renal system, and completely bypasses the health-restoring, longevity-based principles of true medical replacement therapy. To wrap it all up, exogenous testosterone is a profound, incredibly powerful medical tool that has life-altering benefits for men suffering from genuine clinical hypogonadism. But the moment we conflate a carefully managed TRT protocol with a bodybuilding cruise, we'll lose the science and we'll lose the safety profile. True TRT is about biological homeostasis, utilizing sub 100 milligram doses to precisely mimic natural human physiology and protect long-term systemic health. A cruise, on the other hand, is a strategic supraphysiological bridge designed to preserve extreme, unnatural muscularity at the direct cost of prolonged endocrine suppression and severe fertility degradation. Whether you are a patient desperately seeking your health back or an athlete managing a massive physique, you must absolutely respect the profound pharmacological power of the compound and understand exactly how it's permanently rewriting your biological baseline. If this deep dive clears up the dangerous confusion between clinical TRT and underground bodybuilding protocols, smash the subscribe button, drop a like, and tell me down in the comments what subjects would be good choice for future episodes. Base your protocols on real data. Trust the science, and I'll see you in the next video.